Hello, everyone. Thank you for joining us in this inaugural podcast for Cases Neurology. My name is Tom McAnea. I am a GP in Sheffield, and I'm one of the Cases Neurology GP reviewers. I'm delighted to be joined by one of our consultant mentors, Dr. Fiona McKevitt, a consultant neurologist at Sheffield Teaching Hospitals. Fiona, welcome, and thanks for giving up the time to take part today.
Hi, Tom. Thanks for asking me.
Great. So the main focus of the podcast will be around the neurology top 10 tips as set out on the PCS Cases website. In fact, there are 12, although we will be looking at, in particular today, headache management, as well as some other common neurological presentations in primary care. So Fiona, can we start with migraine? This is a very common presentation in primary care and can be difficult to manage for both patients and doctors. Can you start with some key principles of diagnosis?
So migraine is really common. 10 million people in the UK have migraine, and 1 in 3 women at some point in their lives will experience a migraine. And the first step is to make that positive diagnosis. So patients will often use the word migraine to describe a bad headache, but migraine itself actually has clear diagnostic features. Typically, a migraine headache is moderate to severe. It's pounding or pulsating in quality. It can be associated with nausea and vomiting, a dislike of lights, a dislike of noise. It's aggravated by movement. And without analgesia, it lasts a minimum of 4 hours. It may be unilateral, but often it's not. And I find that a really useful question to ask the patient with recurrent headache is to ask what do they prefer to do when they have their headache. And if they answer they want to take themselves off to a dark room, they want to go lie down in bed, then it's highly likely what we're dealing with is migraine.
Thank you. And what about management? How should GPs approach managing these patients?
Well, there are 3 steps, I think, in the management of migraine. And the first, which is a really important step, and I spend quite a bit of time doing this in clinic with my patients, is to assess lifestyle factors. So people with migraines prefer the status quo. That is, their migraines prefer the status quo. Any changes to sleep patterns, so too little sleep and occasionally too much sleep, increased levels of stress, hormonal shifts, unaccustomed exercise can all trigger migraine. Skipping meals or certain foodstuffs can also trigger migraine. So it's really important to make inquiries about this, particularly about sleep and mood. Improving sleep patterns and addressing any stressors can be incredibly helpful. And with regards to dietary triggers, these are things like cheese, alcohol, chocolate, caffeine, citrus fruits, and monosodium glutamate, which is found in Chinese cooking. These can be triggers for migraine, and they're said to be a trigger if the migraine occurs within 6 hours of ingesting the foodstuff. The next step, so that's lifestyle, the next step would be looking at treatment for the headache, the migraine itself. And there are various options at this stage. So there's simple analgesia, which can be combined with antiemetics. And the antiemetic, well, it'll help the nausea, but also it helps absorption of the tablet because peristalsis slows down during migraine. There are triptan medications, so these are dedicated analgesics for migraine. And if one triptan doesn't work, the recommendation is you try another because it's not a class effect. Different patients will respond to different triptans. And there's now a newer agent, a CGRP inhibitor, which can also be used in acute treatments. And then finally, if patients are having frequent migraines, and what we mean by this is more than 4 migraines a month, you can think about regular prophylaxis or preventative treatments. And it's worth noting that preventative is said to work if it reduces migraine frequency by 30 to 50%.
Okay, and in terms of the specific medications, I know you recommend that we look at the BASH guidelines. Can you talk a little bit about that?
So the BASH guidelines are an excellent resource for migraine, and in fact for all things headache. So that's the British Association of the Study of Headache, but also on the Primary Care Sheffield website, on the Cases Neurology section, we have a document, a guidance all about migraine and management of migraine. When it comes to prevention, there's a range of options available within both primary and secondary care. So drugs such as amitriptyline, candesartan, topiramate, and then we have treatments which are available currently only in secondary care. So they are the CGRP inhibitors and botulinum toxin.
And just to be clear, we shouldn't be prescribing sodium valproate anymore as prophylaxis in either men or women. Is that right?
So there's guidance now actually for both sodium valproate and topiramate, there's the Pregnancy Prevent programme, and that's applicable now for both of those drugs. For sodium valproate, that's applicable for both men and women. For topiramate, that is just new guidance coming for women of childbearing age. And if patients are on these medications, they need to sign an annual risk acknowledgement form.
Thank you. And going back to something you said about triptans and trying different kinds of triptans, because some patients will respond to one and not to another and so on. Is it also worth thinking a bit about the mode of absorption, so the kind of triptan? So what I mean by that is using wafers as opposed to tablets or sometimes intranasal sprays. Are those worth considering, trying different types?
Yeah, no, for sure. That's a really good point. So what we recommend first line is sumatriptan tablets. And that's there's a good evidence base for sumatriptan, and it's very cost effective. However, if that doesn't work, it is definitely worth thinking about an alternate triptan or an alternate mode of delivery. So rizatriptan, there's aura-dispersible tablets, which tend to work really well, or the wafer melts. There's sumatriptan injections, or there's nasal preparations. The other thing to do is to combine the tablet with an antiemetic as well. So there's different things we can do, things that we can think about to make the treatment more effective for our patients.
And definitely it's a case of sort of trial and error with patients, isn't it? As you described, trying different combinations and different types of preparations to try to get the best control for any individual patient. In terms of, there is another treatment that's recently become available. Can you talk a bit more about Rijimipant? That's a new treatment, and can GPs prescribe it?
So this is a new treatment. It's one of the CGRP inhibitors, and this is a new class of drug which is available for the treatment of migraine. There are currently 6 licensed in England for the use in migraine prevention. 4 of these are given subcutaneously, 2 are oral preparations. Rimegepant is an oral wafer melt. It's placed under the tongue, but it's currently unique in that it has 2 licenses for migraine. It can be used in prevention, but also as an acute treatment. The dose is the same for both. It's both 75 milligrams, but in acute treatment, obviously we use that as required. For prevention, it's taken on alternate days. And throughout the country, whether GPs can prescribe this, actually it varies from ICB to ICB. Currently in South Yorkshire, it has green traffic light status for acute treatment. So GPs can prescribe this as an acute treatment for migraine. For prevention, it currently has red status, so it is initiated and prescribed only in secondary care. Potentially this may change to amber G, but currently it's red, but it can be prescribed by GPs as an acute treatment.
Thank you. And in terms of when a GP has tried different types of medications, both abortives and prophylactics to manage patients with troublesome migraine, and they're thinking about referring to neurology, what would it be reasonable to expect the GP to have tried before making the referral to the specialist, given the long waiting list and so on? What would you sort of describe as being the ideal in terms of the workup in primary care and what's been tried first?
So there is an expectation that preventatives have been tried. I think the exception to that would be is if a GP wasn't comfortable with the diagnosis, wasn't sure that the diagnosis was correct, and they were wanting support and advice with regards to the diagnosis. But if you're confident that you're dealing with migraine and you've tried acute treatments, you've managed lifestyle factors, and you've also tried 2 to 3 preventive drugs, then that's the stage that it would be appropriate to be referring to secondary care, because we have additional agents that we can give, be it Botox or be it the CRGP inhibitors. We can consider those. What's really useful in a referral is if we know what drugs have previously been tried and to what dose, and the reason for stopping, whether that was due to side effects or whether that was because they were ineffective. And often what we find is a small dose of a beta blocker has been tried, or a small dose of topiramate previously was tried, and actually it's worthwhile knowing what the dose is, because sometimes just going up slightly higher and titrating those drugs further can be helpful.
So it's always worth persisting with patients, I think, is the message, whether assuming patients can tolerate the medication, to try and continue titrating up that the dose in order to see if they start getting relief from their symptoms. I've certainly had some patients who have had to get up to 40 or 50 milligrams of amitriptyline, for example, before they start seeing some significant impact on the frequency and severity of their migraines. And I know that the BASH guidance, I think it sets out in detail the different steps that you can take, and also going back to what we were discussing in terms of triptans, choosing different triptans and where they provide more benefit in some areas than others. Some are faster acting, for example.
Yeah, and we've done this. We've made this migraine management document available as well, which is largely based on BASH, but it's in a much more condensed form. And what we've put in that are the steps to take. So for the acute treatments, what the first line, second line, third line steps would be. So for example, the newer drug, rimegepant, the nice guidance is quite clear about when that can be used. So this is when 2 or more triptans have been tried but failed, or if a patient can't take a triptan because it's contraindicated. So for example, they've had a TIA or they've got ischemic heart disease, triptans are contraindicated. So if simple analgesia has been tried and has not worked, then that would be an indication. So we outline that in our document, which is available on the website. But also with preventatives, we talk about the different options, what dose to start and how to titrate that up. So there's some really clear guidance, hopefully, which is available to help with the titration process.
Thank you. Again, sticking with migraine, should GPs be ordering brain imaging, CTs or MRI scan? Is that something we should be doing?
So that's actually a really interesting question, and it probably would be a podcast debate in its own right. But for the purposes of this podcast, I'll try and keep my answer brief. But you might not need to do imaging at all. So migraine is a clinical diagnosis. If you're confident with the diagnosis, the patient's got a normal neurological examination and there are no red flags, so headache red flags, then imaging isn't always necessary. With regard to headache red flags, again, we do list these in that migraine management document, because missing something significant, such as a brain tumour, is obviously everybody's concern. So we do have information about what headache red flags to think about. But the couple I'd probably mention here are the side lock headache. So someone's got a history, it sounds very like migraine, but it only ever affects one side of the head. I would just have a lower threshold then for wanting to image to make sure there's no underlying intracranial pathology there. If migraine is presenting for the first time in an older patient, so this is somebody over 50, again, I would just be a little bit cautious and I'd want to think about the imaging. And if someone's presenting with a new headache and they've got a previous history of cancer, again, the threshold for scanning would be lower. And if I was going to choose imaging, my imaging preference would be MRI scan in those circumstances.
What about in teenagers? We've certainly had adolescents presenting in primary care with histories of chronic headache. Is the approach the same? Should we have a lower threshold for referral in? Do we need to think about other things?
So I think, again, with teenagers, particularly older teenagers, it would definitely, those same principles would apply. So if you're making a positive diagnosis of migraine, so migraine has those key features, and if it's fulfilling those key features and you're very confident what you're dealing with is migraine, normal neurological examination, then and no red flags, then for sure that same approach is completely appropriate. The caveat would be so chronic headache is obviously different to migraine. So if you've got a daily persistent headache, in children in particular, if it's occipital, we'd be very concerned that that might signify an intracranial pathology. So particularly with the older teenagers, those same principles apply. With younger teenagers and with children, posterior headaches would be a concern. And I think if a child was presenting with a chronic daily headache, you know, you would maybe have concerns.
Thank you. So moving on, another common presentation is blackout or loss of consciousness. Patient reports a faint or an episode, a funny turn. What are your key tips for how GPs should approach diagnosing and managing these patients?
So blackouts have a variety of causes. So it could be a simple faint, so vasovagal syncope. It could have a cardiac cause, so cardiac syncope. It may be an epileptic seizure, or it could be a functional dissociative seizure, which we previously used to call non-epileptic attack disorder. The key, similar really with migraine in making the diagnosis, is with the history, but this actually may also include the need for an eyewitness account. With regards to fainting, so vasovagal syncope, I think the 3 Ps is a really useful tool. So if you think about what position the patient was in, so were they standing? Were there any provoking factors? So for example, were they in pain? Or were there any typical prodromal symptoms? So lightheadedness, feeling warm, darkening of vision, muffling of hearing. Then you would think vasovagal syncope. And the DVLA used to say that if those 3 Ps, those rules are fulfilled, so there was a clear provoking factor, the patient was standing and they had typical prodromal symptoms, that would not stop somebody from driving. So I find that a really useful tool to think about vasovagal syncope. If somebody's got structural heart disease or coronary heart disease, you're going to want to be thinking more, could this be cardiac syncope? And you would want to be going more down cardiological investigations. And I think it's worth thinking about how long the attack lasted for and how quickly people recover. So in syncopal episodes, typically it's brief. The loss of consciousness is brief, and recovery is rapid. I think there's a couple of things to take note of. So convulsive movements can be seen in syncope. So we often get referred up people with everything else sounds very much like vasovagal syncope, but because convulsive movements were seen, there's a query that could it be a seizure? But this can occur in syncope, particularly if the patient remains upright. And the other thing to think about is that the duration of loss of consciousness. Now, obviously, a patient can't tell you that, but the eyewitness can. But quite typically, we're really bad at predicting or saying how long a period of loss of consciousness was. So I will often get a history. It sounds very typical for vasovagal syncope, but the loss of consciousness was said to be about 5 minutes, 5 to 10 minutes, which would be very unusual for syncope. So a trick that I have with when I've got the eyewitness is I actually time in clinic, I'll time it with them, and we all go silent and I just ask them to tell me when the patient recovers. And invariably it's a few seconds, and then you're very confident that what we're dealing with is vasovagal syncope. For epileptic seizures, things that would make a diagnosis of an epileptic seizure more likely is if you're obtaining a history that the head turned to one side, or there was recurrent limb jerking lasting more than 10 seconds, or there's unusual posturing. There may be vocalizations during the attack or snoring afterwards. Patient may have bitten their tongue. Confusion afterwards is prolonged, and what we mean by that is by more than 1 minute. And for me, a sort of real red flag that what I'm dealing with is an epileptic seizure is if there's amnesia afterwards. So a patient, what I ask a patient is, what is your next memory? Where were you when your next memory kicks in? And if we're getting reports from eyewitnesses that they woke up at home, the paramedics arrived, they walked into the ambulance, but the patient is telling you that their next memory is waking up in the emergency department, they've got significant post-event amnesia there, and that would make an epileptic seizure much more likely.
Okay, thank you. And so really it's about trying to, the key as ever is, it lies in the history. If, going back to your point about a patient, if something does sound very syncopal, but they have had movements whilst they've been in this episode, do you think it's still reasonable to refer to the clinic for suspected epilepsy? Or do you think GPs can feel confident in managing those patients as a syncopal episode?
So, I mean, again, I think it is your degree of confidence when you've taken that history, and particularly if you've got a good eyewitness account. If there's just a short period of convulsive movement, so less than 10 seconds, and everything else about the attack sounds like syncope, a vasovagal syncope, then I think you can be pretty much confident that's what you're dealing with, but it's your level of confidence in making that diagnosis. What we do say is simple faints don't need referral unless they're recurrent, or they're occurring in a sitting position, or if they're occurring without typical prodrome. Seizures are referred, if there's a query of seizures, that's referred to neurology, but unexplained transient loss of consciousness, which isn't consistent with that simple faint or isn't consistent with seizure, they should be referred to cardiology.
And finally, any patient that we are referring to neurology with blackouts, loss of consciousness, are there any particular investigations that ideally you would like to have done in the community before they get to clinic?
I think the most important investigation, and this is for anybody who is presenting with transient loss of consciousness, is the 12-lead ECG. And what we're looking at in particular is the corrected QT interval. So prolonged QT, it's a risk factor. Cardiac arrhythmia can present with transient loss of consciousness. So it would be really important in all patients. And I do this even if there's a really good going history that I think is consistent with epileptic seizure. There's unfortunate examples available in the medical literature where it was actually prolonged QT syndrome that was the problem. And so a 12-lead ECG would be the test I would recommend for all patients.
Thank you. Can we move on to tremor? Another common presentation and one that can have a significant impact on patients' function. How do you approach the diagnosis of tremor?
So again, tremor is another common reason for referral to the neurology clinic. And often the concern that patients have or the referrer has is that it may be due to Parkinson's disease. But essential tremor is at least 8 times more common. And certainly I see that in my own practice, in my own experience. For every 10 patients that has been referred to me with tremor, 9 of them will have a diagnosis of essential tremor. And I think it's probably worth, therefore, knowing some tips to help distinguish between those two forms of tremor. So the tremor of Parkinson's disease predominantly occurs at rest. So this is different to essential tremor, which occurs with actions, so writing, eating, drinking. Patients with essential tremor may have difficulties eating soup or keeping their peas on a fork. They may notice difficulties with activities that require fine motor skills, such as using a screwdriver. Essential tremor has usually been there for years rather than months, and there may be a positive family history. They may also notice that alcohol has a positive impact on their tremor. But in clinic, what I find is a really useful tip to distinguish between the two is to ask a patient to draw an Archimedes spiral. In Parkinson's disease, that spiral will be tightly drawn together. The lines may cross over. In essential tremor, the spiral is still the normal size, but is very tremulous. And just that simple getting the patient to draw that spiral can really help distinguish between the two. The other thing to think about with tremor is, could it be drug induced? So there's certain drugs like sodium valproate, lithium, excess salbutamol use that can cause tremor. So thinking about the drug history and whether there are any drugs that can cause tremor is probably worth considering as well.
Thank you. And management, what can we offer these patients?
So clearly management will depend on the cause of the tremor. Not all patients with essential tremor need treatment with drugs. Sometimes actually reassurance is all that is required, and often that sort of reassurance that they don't have Parkinson's disease. But to help reduce symptoms of essential tremor, there are some lifestyle tips that can be given. So avoid caffeine, reduce stress, think about relaxation techniques, using heavier cutlery when eating, drinking through a straw, typing instead of writing. There's some simple strategies that people can use. There's also a really good website, so www.tremor.org.uk would be a resource that might be helpful for patients. And then if you are going to think about medical treatment for essential tremor, then first line treatment is propranolol. If that's contraindicated or has proven ineffective, primidone can be considered. And the tip with both of those medications would be to start at a low dose and titrate up. Initially with medical treatment, you might not even need regular treatment. It might just be it's needed on an intermittent basis. So for example, patients, when they go out to a restaurant, they may find it a little embarrassing that they've got a tremor in that environment. So judicious use of a small amount of alcohol can be helpful, or having propranolol 30 to 60 minutes before they go out to do that social activity, rather than taking medication every day. So medical treatment could be intermittent at first or then regular. Propranolol is first line, primidone second.
Great, thank you.